Good afternoon, everyone. Thanks for joining us on our special July office hours. Wanted to thank you for attending, especially in this dreary weather today. So hopefully we can give you some good information. The reason we're having this special office hours is because we had 8 policy and procedure updates in the last month and a half, and we just thought it'd be fitting to take some time and walk through those today versus just sending out in our traditional email format. So that's why we are meeting. So let's get started. As I had mentioned, it's going to be a policy and procedure update and overview for 8 policies. Those policies are going to be the Comprehensive Assessment Policy, Disenrollment Policy, Hcbs Rights and Choice Policy, Health Home Qualifying Conditions Policy, the Health Home Supervisor and Caseload Ratios Policy, Informed Consent Policy, a Palliative Care Bereavement Services Policy, which is a new policy for the Health Home, and then referrals and assignments. So with that, I'm going to do a switch over on screen share, and we're going to actually pull up those policies and walk through those individually. And Jessica Robertson is going to lead that discussion while I drive through those policies on my end. As always, this is being recorded, and it will be available on our Health Home Trainings webpage. And if folks have questions along the way, please unmute yourselves and ask away or comment away. And we also have the chat feature as well for folks. So with that, I'm just going to stop sharing briefly, and then we'll start with the Comprehensive Assessment Policy. All right, can everyone see my screen okay?
Yes.
All right, great. So Jessica, I'm going to turn it over to you, and I'm going to start to scroll down through. So tell me when to stop, but we'll start with our Comprehensive Assessment Policy.
Okay, you can scroll down. Scroll through the definitions. That's good. So the first policy we have for review that's recently been updated is the Comprehensive Assessment Policy. This was updated for an annual update. It also was updated to include a change to some of our qualifying conditions for Health Home. Sickle cell disease has been added now as a single qualifying condition. So we updated this policy to reflect that. Then it was also updated based on some of our redesignation results. What the state was finding when they audited our comprehensive assessments is that when we were identifying needs in our comprehensive assessments, those were not being carried over into the plan of care. So as you can see up here at the top of the page, we have the categories that we must include in our comprehensive assessment according to state policy. So those are addressing medical needs, social determinants of health, behavioral health, rehabilitative services, long-term care services, social support needs, social service needs, substance use, ADLs, and then we must assess risk factors associated with HIV/AIDS, and then other behavior risk factors for children. And what they discovered is that if we identified a need in one of these areas, they were not seeing a correlation between the need and a plan of care. So moving forward, we just want to make sure that anytime we identify a need in our comprehensive assessment, that is being carried over into our plan of care in some capacity. Now, the plan of care is also person-centered. So if there is a need identified in the comprehensive assessment and the member that you are working with does not want to address that need in their plan of care, then there needs to be a note correlating to that member stating that they do not want to address that need. So that would be one of the most important takeaways and updates to the policy. Also, just a reminder that our comprehensive assessment is due within the first 60 days of enrollment and then annually thereafter, and that Taylor will send out reports and is also available in DataDen when your comprehensive assessments are due. I'm not going to read through the policy in its entirety. They've been distributed, and I encourage everyone to read through all of the policies. So when you collect your documentation to do your comprehensive assessment, it is lengthy. It's about, I think it's 17 tabs long. And if you print it, it will appear even longer because it doesn't have the back-end information to make certain questions disappear. So you do have to click through the whole thing. Right now, not everything is required in the comprehensive assessment. If it's required, it will have a red asterisk noted next to it. Right now, we ask you just to fill in information that would obtain to your client. And then when you do your annual update, a lot of that information does carry over. What we have been noticing and what's been noticed in some of our audits is that there's a lot of missing information. For example, if you have a kid who is enrolled in Hcbs for SED and you go to their comprehensive assessment and then the risk factors and behaviors section is completely blank, that does not correlate to that kid actually needing Hcbs because there's 0 risk factors noted. You just want to make sure that when you're going through your comprehensive assessment that you are answering the questions that are applicable. For instance, the last tab in the assessment is a priorities tab, and it's a free text box. No, I don't have a red asterisk on it, but that should really encompass you've gone through the entire assessment, you've assessed all the needs that the member may have, and when you get to that last tab, it really allows you to ask them, like, okay, we've gone over all of this, but what are your priorities and what would you really like to focus on? So we would like to see that last tab be filled in and not left blank. Also, when you're completing the comprehensive assessment, you can use other sources of information to help complete the assessment. So when you go to sit down, you're not asking question by question with the member. You've gathered some of that information from the referral source, if the information came with a referral, so your intake process, any information you've gathered when you've looked in psyches, or if you've pulled a Hcbs, DCD, you can use all that information to help fill out the comprehensive assessment ahead of time. Does anyone have any questions on the comprehensive assessment? Okay. Travis, did you have anything to add that I missed?
No, very thorough. So next we'll move on to disenrollment. And as always, if you have questions after the fact, anyone, please feel free to reach out to us and we will connect with you and answer your questions. So disenrollment is our next policy.
So disenrollment, one of the major changes with our disenrollment policy is that we no longer need withdrawal of consent form signed. That was effective, well, initially it was supposed to be effective in April of 2022, and then they put a hard issue date for May of 2022 on that. So our members, when they are disenrolling from health home, and we've had a conversation with our members about disenrollment, so you've had a phone conversation, a face-to-face conversation, as long as one of those two things have happened and they are in agreement with their disenrollment, they no longer need to sign withdrawal of consent forms. So you no longer have to have them complete the 5058 or the 5202. What we do need to do is for every single member who disenrolls from health home, they do need to be issued a letter on agency letterhead that lets them know that they have been disenrolled from health home and that information, PHI information sharing has ceased as of the date of that letter or the date of disenrollment. This issuing that letter allows us to not have to have withdrawal of consent forms signed anymore. One of the forms that is still in place is that 5235 notice of disenrollment. That form is still a form that needs to be distributed to anybody that you have not been able to have a conversation with about disenrollment. So those would be the biggest update to this policy. Also, if you walk through the policy, if we really want to take into consideration when we discharge members who are part of that high-risk population, so that would be our Health Home Plus members, our HEART members, and our Hcbs members for children. We want to make sure that we are not just ending care management for them, that they have either a step-down plan or a plan. And because it is, except for our AOT population, is a voluntary program, we want to make sure that they are in agreement with their discharge and that a conversation has been documented. And if they do not wish to stay enrolled and do not wish for any other type of services, that it's been offered to them and that you're documenting that in the record. And when you're discharging any of those high-risk populations, you want to make sure that the care team has been notified. So whoever's working with that member, that they've been notified that that member is no longer participating in health home care management. And then again, especially for those high-risk populations. Then this kind of goes through the reasons that you would discharge or circumstances that you would discharge a member. There are various reasons that you can disenroll a member from health home. We want to make sure one of the bottom tabs there, it says disengaged members. So disengaged members are members that have disengaged from health home care management. You want to put them into diligent search to see if you can re-engage them. If you were unsuccessful in their re-engagement, then you would go ahead and discharge them. You can keep going down, Travis. Then this will go through the various steps. You want to make sure that your supervisor is involved in the discharge, that they're in agreement that the member should be discharged from health home. Again, you want to make sure that you document any refusals on that member's behalf to participate in the disenrollment I lost my word, meeting.
Process.
If they don't want to meet with you, there you go, process. If they don't want to participate in the process or have a conversation with you about it, we want to make sure that that is all documented so it doesn't look like the member was just dropped from health home. All of those conversations or refusals to participate in those conversations do need to be documented. Another piece of documentation that was noted by the Department of Health is our transfers. A lot of times we'll transfer members from CMA to CMA or from a CMA to another service. They really want to make sure that we're documenting those transfers thoroughly in our records so that we're having warm handoffs wherever possible. So it's not just as completing that transfer form, but really making sure that CMA-A is communicating with CMA-B about that transfer between those two agencies. Also, CMA-B will not have access to any of that member's record in NetSmart from CMA-A, so making sure that they communicate about any important documentation that needs to go in between those two CMAs. If you want to scroll down. Again, I'm not going to read through this. This goes through the various reasons for disenrollment and what to do. Most importantly, with this policy, you want to make sure that disenrollment is a collaborative process, that we're not just dropping people. If we are working with members who can be verbally abusive to staff, they may physically threaten staff. We want to make sure that we're not closing them for health and safety concerns. You really want to reach out to the health home before you close any of those type of members. If you have a member who is verbally abusive or is making physical threats towards staff and it's someone that you no longer want to work with, you should make a transfer, as long as that member is in agreement, to the health home and or loop the health home in at any given time. If we have members like that, we want to keep them either in the same CMA and change care managers. we can't keep them in the CMA and you no longer want to work with them or cannot work with them any longer, please connect with us at the health home so we can find another CMA to pick them up or determine that they truly do need to be closed for that reason. The Department of Health does look at every member who is closed for that health and safety end reason. That is what they call like a red flag end reason. So we want to make sure that we have thoroughly documented if we really do close anybody for that reason. And then post-enrollment re-engagement, again, the program's voluntary for everyone except for those in AOT. So if someone does disenroll or graduate from the program, as long as they are eligible, they can come back at any time. And that they can come back straight to the CMA, or sometimes they funnel through the health home. Whenever we get a referral, we will always look to see the last CMA that serves that member. And if they have capacity, Courtney will always reach out to see if you want to re-pick up that member. Right here, this goes over members not progressing towards goals. So another reason to disenroll or to have a discussion about disenrollment or graduation would be if that member is not progressing towards goals or not engaging in care management. Their plan of care is person-centered, and it should always be stuff and things that they would like to work on or things that they would like support with. So if we're having a member who is, difficult to work with or not progressing or not engaged, we want to make sure that their care plan is reflective of that. And then we want to work towards graduation for those folks. Keep going.
Jess, I just wanted to add to that, it really should be a transition plan as much as possible. So back to the comment earlier that Jessica made, that we should try not to be abruptly discharging someone. If they're working toward graduation or step down, it should be a mindful, collaborative process that may take, 60 days possibly, as far as transitioning with that person and their team or social supports and specialty providers. So if at all possible, that should be part of the planning process towards a discharge.
Another reason to disenroll members would be members who no longer meet criteria. We work with members who have one single qualifying condition or chronic conditions. Generally, those single qualifying conditions or chronic conditions are not going to heal themselves and they'll be in recovery from them. But what they would no longer meet the criteria for is that they no longer meet the risk factors to be enrolled in the program. So through working in health home, they've resolved some of their risk factors, or they no longer have active Medicaid. If their Medicaid lapses and they just need to recertify, you can continue to work with them and help them through that process. But if they were to completely lose their Medicaid and then no longer be eligible, they would not be able to be enrolled in health home. And then at that point, if they still needed assistance, you could look at what was offered in the community to help them with like a non-Medicaid care management. And keep going down. Again, individuals who are abusive to staff, I touched on this earlier. You always want to make sure that you are reaching out to the health home to discuss these members. We don't want to just disenroll them due to their behavior. We should be working together to come up with a plan to transfer them or actually close them or do telephonic care management if in-person care management is going to be unsafe. Disenrolling children from health home is roughly the same process as disenrolling adults. Some of the forms are a little bit different, but like I said earlier, we no longer need to complete those withdrawal of consent forms. We just need to issue that letter, and there is a sample letter that is in this updated policy.
Does that include the 5204 as well?
No, so you still have to have the withdrawal of consent forms for educational records.
Okay, so just the 50/50, just the 5202 and the 50/58.
Correct.
But the 5204 remains in play.
Correct. You still have to have the withdrawal of consent for educational records signed at disenrollment.
Okay, thank you.
If you can. Yep. You can keep going. These are just a couple of notes on forms. And I think that's it, except for if you want to scroll down, we have a checklist, we have discharge letters, we have the tool for what form to use and when to use the form. And then this right here is a sample letter that you can use to draft to your disenrolled members. So any member who is disenrolling from health home care management, regardless of the reason, needs to be issued this letter. Anyone have any questions on disenrollment?
Okay, moving on to referrals and assignments policy.
Just one thing on forms, because we just touched on forms. It is very important that whenever you are completing a form or having a Department of Health form signed, and this could be any form, that the form in its entirety is filled out and uploaded into NetSmart. I am seeing a lot of forms that are missing information, or check boxes aren't checked appropriately, or they'll upload part of the form and not the entire form. When we are audited, they audit us to see if the form is filled out correctly. So if you miss something on the form, we don't get credit, even if the form is there. And if you miss a page when you upload the form, you also lose credit because the entire form is not present in the record. So you just really want to make sure that you double check everything before you upload it to make sure that it's completely filled out and that the entire form has been uploaded into NetSmart. So our referrals and assignments policy, this was just an annual update, except for adding sickle cell disease when making a referral. There were no other changes to this process. The process still remains the same when you make referrals to the health home, how we get referrals into the system, and then you can also have the form completed. Courtney can put them into NetSmart, or some of our CMAs have the ability to enter them into MAP, and then we get them into NetSmart. So this process has not changed, and there have been no updates besides adding sickle cell disease to this policy. Does anyone have any questions on referrals and assignments in NetSmart or through MAP or the policy itself?
And then there's a desk guide in the back just for those that have access to MAP to be able to enter someone in as a resource. We'll move on to the next one, Jess. Qualifying conditions or qualifying criteria.
Yep. So this is qualifying conditions policy. This was recently updated for two reasons. One, it was updated to include sickle cell disease now as a single qualifying condition. And secondly, it was updated due to redesignation because the Department of Health wanted to see in policy that each child being served in children's health home was being addressed for risk factors for a higher level of care and being offered Hcbs if they would meet that higher level of care. So those are the two updates to this policy. Basically, qualifying conditions, it's self-explanatory. You want to make sure that everyone we enroll in health home has active Medicaid. They have a single qualifying condition or two chronic conditions that meet policy criteria. And then they also have those risk factors and appropriateness criteria for health home. And you want to make sure that you're verifying the eligibility, you're verifying the Medicaid, and that you're uploading in external documents proof of those qualifying conditions or proof of those single qualifying conditions. And then this goes through various ways. You can collect that documentation to upload into the member's record. Verifying ongoing eligibility, that member will have to have active Medicaid every month to be enrolled in health home care management. If they lose their Medicaid, again, you can help them recertify. And if they're going to permanently lose their Medicaid, then they can be routed to a non-Medicaid CMA for non-Medicaid health home, and you would do that through the SPOA process. And you could offer the family or the member you're working with that as an option. And I think that was it for this policy. I did add, I don't know what page it was on, but I did add a note about assessing children for Hcbs in a higher level of care. This basically, as you go through the comprehensive assessment or you're meeting with the referral source or where you get the referral source sometimes can help with this determination. But any of the kids that we serve in Children's Health Home, if they are at risk for a higher level of care, so that could be an inpatient hospitalization, an RTF, an RTC, foster care would be another higher level of care, that you are talking with the family and assessing if they would potentially could benefit from Hcbs. And if they have some of these risk factors, if they'd like to pursue it, then you've had a documented conversation with the family and you could put that in the record. Or if you have a conversation with the family about Hcbs and they choose not to pursue that, you can also document that in the record that, yes, they could be at risk for a high level of care, but the family's decision is not to pursue Hcbs at this time. And then they would have access to potentially some other services in the community rather than going through the Hcbs process. Also listed in our policy is this appendix that goes over every single chronic condition that would make someone eligible for health home. And if you ever have any questions on a diagnosis, you can always reach out to us and we can help you determine if that is an eligible diagnosis or not. Anyone have any questions on this policy?
Supervisor and caseload ratios.
So this one, there was no changes. It was just an annual update. So none of the policy has changed. So if you had read the policy once, it remains the same besides the updated date on here. Really, it just goes over caseload ratios for all of our populations for adult health home and for children's health home. In this document, we also have some appendix that go over examples of how you can determine caseload ratios for the members that you serve. Most of our CMAs use that mixed caseload for adults and for children, and there's examples in here on how to determine that. Did you have anything to add to this one, Travis?
No, that was the only, just that it was an update.
Yep, that's all I had.
So hopefully these desk guides are helpful because we try to give a number of different examples of how caseloads could look if folks chose to do that mixed caseload approach. Okay, so home and community-based service waiver, rights and choice for children.
Okay, so this policy only pertains to children enrolled in children's health homes that are actively have a level of care and are receiving Hcbs services. This is an annual update to this policy. There were no changes to this policy when I updated it. A couple of reminders, though, that when you have a youth enrolled in the home and community-based waiver, we want to make sure that every time a level of care is completed, that you have an updated freedom of choice form. So that's that DOH 5276. Every time a level of care is completed, either initially or annually, whether they are eligible or ineligible, the 5276 needs to be completed and uploaded into the record. Another piece of information that we learned through redesignation and through our Hcbs audit is that our auditors are looking in the notes to make sure that we have reviewed this form with our family. So they're looking for documentation that we had a conversation with the family about the form. So even though the form's in the record and has the parent or guardian signature on it, they're looking for a correlating note where we reviewed this form with the family. And basically this form discusses that we gave the family the right to choice when choosing a CMA, a health home, and a provider for those services. It also informs the family on how to file a complaint for Hcbs services, report abuse, or if they are in disagreement with the decision, how to file a fair hearing and request a conference. So those are the biggest takeaways to make sure that this form is completed correctly. Every checkbox is checked, it's all signed. It's uploaded in its entirety, and that there is a documented conversation in the record that you reviewed this form with the family. Does anyone have any questions about this policy?
Okay, moving along to informed consent.
All right. Informed consent had a lot of updates, and these updates were related to some changes in the forms. So effective this April, May, it was supposed to be April, then it got moved to May. The children's consent for enrollment in health home, the DOH 5200, is no longer in use. So anyone enrolled after April 1st, they will not sign that DOH 5200. They're to only sign the updated children's 5201. Also within the 5201 now, that also encompasses that functional assessment consent. So that would be consent for the UAS to enter the CAMS. So that DOH 5230 is no longer in use. And we no longer have to have a separate consent for children for psyches, that's also now in the updated 5201. Also in this policy, the 5059, or that opt-out form, is no longer a form that needs to be completed when you do outreach with a member. And then, like I covered in disenrollment, the withdrawal of consent forms are no longer effective. All you need to do is have a documented conversation with the family about disenrollment, and then issue them a letter that states that the consent has ended with disenrollment in health home. With the new 5201 for children, we used to have two sections to that consent form. It was section 1 and section 2. Those still remain the same. However, if they choose not to complete the second section for whatever reason, there is now a separate tracking form. So before, care managers used to write a note on section 2 or write a note in the record as to why it wasn't completed. Now you need to complete that tracking form. So if section 2 on the 5201 is not complete, you have to make sure that that tracking sheet is completed and uploaded into the record. And that needs to be reviewed annually with the family. Like I said before, the disenrollment form, so that withdrawal of consent piece has ended. However, you have to issue that disenrollment letter. If you cannot have a documented conversation with the member, so face-to-face or telephonically about disenrollment, then you do still have to issue the 5235 10 days prior to disenrollment. So if you're going to disenroll someone the last day of the month, you have to make sure that 10 days prior to the last day of the month that 5235 has been issued. And then that will give the member notice that they can either call you back and say, hey, this is an error, I really do want health home, or they'll get it and disregard it. Or if they are not in agreement with health home disenrollment, so say you are disenrolling them from health home, they're not in agreement, even though you've had a verbal conversation with them, and then you would still issue the 5235 because that gives that member the right to a fair hearing. So what I would suggest is if you have someone who is in complete disagreement with their disenrollment for health home, that you reach out to us and we can kind of talk out the best solution, because in all likelihood, they will file the right to a fair hearing, and then we will have to follow up anyway. So if you have someone that you're disenrolling from health home and they're adamantly against their disenrollment, to reach out to us and we can kind of talk through next steps. And then like I touched on with forms before, you want to make sure that every single consent form, every single piece of paper, especially a Department of Health form, is filled out in its entirety, that every box has been checked, that every blank has been filled in, that it's been signed, it's been dated, and then you upload the consent form in its entirety into the system. If you miss something on a form, they will mark it as not being completed correctly and you will not get credit. If you upload a form and you miss a page, they will mark the form as not being present in the record because not the whole thing is there. So every time you update a consent form, you have to re-upload the entire consent form. And then with like all of our consent forms, you want to make sure that the managed care company is listed if applicable, that the primary care is on there, CMA, and anyone that you will be sharing PHI with or making a referral to during redesignation, they will cross-check notes. So if you were talking to someone and you note a provider in one of your contact notes, they will pull up your consent form and verify that that provider that you were speaking to in that note is on that consent form. And anytime you send a referral, if they say a referral in external documents, they will look to see who that referral was sent to. They will go back to your consent form to make sure that that provider is listed on your consent form. So it's very important to make sure that before you communicate or send a referral to anybody, that they are listed on your consent form. Does anyone have any questions on informed consent?
Jessica, this is Mary. Did you say that the opt-out form is no longer required for individuals who are in outreach and engagement that choose not to enroll in the program for adults?
Yes, choose not to enroll. Yeah, that 5059 form no longer has to be completed.
Okay. And one other question, if you're sending a notice of disenrollment, the 5235, that letter still needs to go with that notice of disenrollment, or only if it does? Okay.
No. Yep. So through redesignation, they clarified to us that everybody has to be issued that letter, even if you are sending a 5235.
Okay, so I'm just asking because I find the attachments very helpful. And if you go back to the disenrollment policy where it talks about 5235, that's still indicating the 5058 in it. So just so you know.
So they're updating the adult 5055 and they have not sent us a new one yet. So that's why I left it in there. But any day we're getting an updated 5055, which makes the 5058 obsolete, but they haven't taken it out of policy yet. But they just wrote it in a memo that you only needed to do that letter. You won't have to do the 5058. So like on the children's side, anyone who has signed the old forms should be still getting the 5202 for disenrollment. But if you move forward as of 5/1 and complete the new 5201, you do not have to do the 5202. You only need to do the letter.
Thank you.
Mm-hmm.
Mary, we just got. I'm sorry, Jess.
Oh, sorry.
Yeah. I was just going to
No,
mention
go ahead.
quickly that the 5055 is in draft form, and it just went out again for comments and feedback to health homes last week. So it's not there yet. We're hoping it's going to be sooner than later. It's been promised for quite some time.
Yeah, so I was just going to say for what like the 5059 for that opt-out form that you no longer need. So you approach someone, they're in outreach, they don't want health home, you no longer have to complete that form. However, that 5236 form that if you are outreaching someone and they're ineligible for health home and they're denied enrollment into health home, that form is still in use. So you want to make sure that if you outreach to someone and they don't meet health home criteria, and you're going to issue that 5236 still.
Just a quick question. It's Paul. How are you? You just mentioned the for any non-self-consenting child member who signed the old 5200, they need to have the now old 5202 to revoke that consent.
Yeah,
I'm assuming that's only a thing until they sign the updated consent,
that's correct.
right? Because they've
So
got 6 months from May 1st to sign the new 5201.
Yeah. You have until November of 2022 for every child enrolled in health home. In
Right.
children's health home that's not self-consenting will have to have the new 5201 regardless of any update needed come November of 2022.
And so once they've got that, then there's no expectation for the 5202 to be done upon disenrollment.
That's correct.
Okay. Thank you.
Yep.
Any other questions around consents that anybody had or comments? All right, then we'll move on to the last policy update. Actually, a brand new policy, as was mentioned, palliative care bereavement services for health home care management. This is specific to children's health home. Jessica, take it away.
Yeah, so this is our newest policy. It only pertains to health home serving children, and it only pertains to youth enrolled in the Hcbs waiver that are in children's health home. This is a new policy. It is palliative care is an Hcbs service that is available to our youth enrolled in the waiver who have been diagnosed with a terminal illness. This policy allows for bereavement counseling for the family for up to 6 months after the child's passing. And it also allows for 1 additional month of health home care management services past the month that the child has passed on. In order to access the 6 months of bereavement services or that additional month of health home care management, the child's plan of care will have to be updated prior to the child's passing, and the plan of care will have to be approved by the MCO and provider prior to that. So that's the most important piece. So if you're working with the Med-Frag population, this is a service that would be available to them. Well, technically available to anybody, but if particular the medical fragile population, that if you identified bereavement counseling or that additional month of health home care management, they want to make sure that that is in the plan of care and it has been updated prior to the child's passing. It cannot be done retroactively. And this would not be for if there were some type of incident with any of our other children enrolled in Hcbs waiver and they abruptly passed and it was not due to chronic disease or terminal illness. In the policy, I'm not going to read it to you. You guys can read it, but it goes over different examples of what would qualify and how to document in the plan of care either one or both of these services that could be needed. Does anyone have any questions on this policy?
Okay, I'm going to stop sharing again and just switch back over to the deck. So we went over to 8 different policy updates. Any last comments, questions around these? If not, we'll be available if people have questions after the fact or wanted to talk more about any particular policy through our Health Home email, or folks wanted to reach out to us independently, feel free, and we'll answer those questions for you. Just our general slides we typically have, the Health Home team, and then our provider network that's intact currently. And just wanted to thank everybody for their time today. One of the things I did want to mention, we were talking earlier today about if we should hold an office hours next Tuesday still, given we went over so much on policy today. And I just wanted to open it up for those folks on the call today. If you feel that we should hold an office hour still, we don't have a whole lot of new information from our last time we had met on top of what we just discussed today. And knowing that it's in the heart of vacation time for many right now, in the midst of summer, we wanted to throw out there the potential to cancel next Tuesday's meeting. So I didn't know what folks' thoughts were about that.
I vote to cancel it.
You vote?
Because I'm being selfish because I'm on vacation.
Yeah. Well, there's one. We got another aye.
Purdue.
I'm on vacation too.
All right. Well, I think the ayes win. The vacations win. So we'll go ahead. I'll send a cancellation out with a note to the network, just that we're going to hold until August. If for some reason something comes up, we'll definitely be in touch with folks. But we just thought, given the timing of where this fell, but it was very important to have to go over these policies. So, Jessica, did you have any other commentary you wanted to bring up? I know we're starting to finalize the year 3 audit information gathering. Is any message you want to put out there to folks? Outside of a big thank you for everybody who's supplied information, obviously. But any last minute items around that, Jess?
So I will also be on vacation next week, so I also vote to cancel office hours. But as far as updates go, I need to submit that training audit to the Department of Health before I leave for vacation. So if you have not gotten your information back to me, please do that as soon as possible for that training audit. And I am still going through our Hcbs year 3 audit stuff. I have to pull each record together, put it into a PDF, put it into a folder, and send that off to the Department of Health. And I have, I think, 4 left to do. So if I'm missing anything from a record and I've emailed you for that information, please get it back to me as soon as possible, because I also need to submit this before I leave for vacation. And I just got an email from the Department of Health that they needed to add an additional record to our audit. So now I have 1 more to do. So if I need anything, I'll be reaching out about that 1 additional case. So please respond to my training audit request. And if I have anything that I'm reaching out about for the Hcbs audit, if you can please get it back to me as soon as possible.
Thank you,
That's all I
Jessica.
got.
All right. Well, thanks everybody for all your efforts around that to get that information in. I know it's, 1 more thing to contend with, but the state's asking, so we're trying to get it. Renee, I just saw your chat note about increasing the size. I'm sorry. I was full screen, so I didn't see the chat comment. So I apologize if anybody
Don't
had trouble
worry,
seeing.
Travis. I won't take it personal.
Well, I didn't want to not acknowledge your comment there, so apologize. Taylor, did you have anything on the quality end that you wanted since we're not going to meet next week? Any FYI, anything quick for anybody?
Nope, all good. Thank you, everybody.
Okay. All right. Anybody have any questions or anything else before we wrap this up? Again, it'll be recorded. It is being recorded, so it'll be available on the website for reference for folks who are on today and for those who were not able to attend. So we hope it's going to be a meaningful resource for folks. All right. Well, I hope everyone has a great rest of your day. And for those heading on vacation, enjoy. We'll talk to you all soon. Take care.